Evidence-based medicine, as I said, we take something that we all know and we know a lot about, but really shake it out and say, what is the evidence that speaks to this? And it's also a bit of a hot topic with the FDA hearings this week about some aspects of the safety. And I wanted Dr. Fleischmann to tackle this evidence-based medicine, non-steroidals, past, present, and future. And when I asked him, Roy said, "Why did you do this to me? Why did you make me do the non-steroidal talk?" And yet I thought it was actually, he's the perfect person to do it, because Dr. Fleischmann was one of the earliest people in rheumatology to really develop a very big clinical trials activity. And back in the day, many of those trials were non-steroidal. So I knew he had a collection of glass 35 millimeter slides, and then in cardboard. I'll explain to the fellows what 35 millimeter slides are later. The glass slides, then the fancier, lighter ones, and then so I asked him to share some of that experience and also the historical perspective, and they're very happy to have him do that with us today. Roy?
Can I use the stool?
You can stand on that if you want.
I can stand on the stool. So I'd like to thank the half of the audience that stayed for this. This really is, I like to say back to the future, but it isn't. It's back to the Middle Ages. Here are my disclosures. This really is everything you ever knew, but Artie didn't want you to forget. Right? So if you don't like this lecture, it's Artie's fault. If you do like it, it's my delivery. All right, so let's go through the history, and it's actually turned into a much more interesting discussion this week. All right? I'll point out why. So, how old are non-steroidals? 500 years before the Common Era, Hippocrates reported the use of willow bark. And Celsus, 30 years before the Common Era, described inflammation and used willow bark to mitigate them. And in 1761, Edward Stone wrote to the Royal Society of England, of London, describing his observations of the use of willow bark-based medicines in febrile patients. And in 1829, Leroy first isolated the active ingredient of willow bark, its pure form, and described its antipyretic properties. And I think you all know what this is. So it was salicin. And it's by hydrolysis, salicin releases glucose, salicylic alcohol, which can be converted into salicylic acid in vivo and through chemical means. And this is, and salicylic acid is more effective than salicin. In addition to its fever-reducing properties, it was also anti-inflammatory and analgesic. And then in the later part of the 1800s, Hermann Kolbe synthesized salicylate, a word that I think you know, although it was very acidic for the gastric mucosa. And then in the very late 1800s, Felix Hoffmann and the Bayer Company converted salicylic acid into acetyl salicylic acid, named aspirin by Heinrich Dresser, which was much less toxic. So in 1917, this is the ad for Bayer tablets of aspirin. Right? Now this is, I could divert by a while, but this is not the same Bayer that we're used to. This Bayer company was actually a Nazi company, so they had difficulty getting their name back. We can go through that history when Artie asked me to go back into history again another year. So we can talk about classification of NSAIDs. And all approved NSAIDs fall within one of several chemical classes, all of which inhibit COX-1. So that could be the salicylates, propionic acid derivatives, acetic acid derivatives, the oxycams, the phenamates, and the COXIBs. But when we celebrate a COX-2, you've seen protocols where they talk about, an NSAID or a COX-2 selective. COX-2 is an NSAID, right? It just has a little different mechanism. And these are the NSAIDs that are in use or not, right? So these are forms of salicylates, all of which I have used over the years, propionic acids, all of which I've used, acetic acid, all of which I've used, enolic acids, all of which I've used, phenamic acids, and the COXIBs. And I've used all of these, except I've actually used all of these. The miracoxib never made it to market, but we did studies in it. Turacoxib did not make it to market in the US. We've done studies with it. Valdecoxib was Bextra, came and went. FDA didn't like it. Rofecoxib was Vioxx, celecoxib you know. Artie alluded to my having some history with this. I can tell you that the first clinical trial I ever did was in 1973, and it was a brand new drug that was not approved, and the drug was called ibuprofen. So that was my second year of fellowship. My first year of fellowship, the drugs that we used were aspirin and indomethacin and butazolidine. Those were the three NSAIDs. We had gold, we had prednisone, and we didn't have a lot of luck with any of those, right? So when you consider the use for NSAIDs, now first of all, let me ask a question. How many of you use NSAIDs in your patient? Let me see hands. Who doesn't use NSAIDs? You don't use NSAIDs, ever, okay? How many of you are using NSAIDs less than you did? So is that less frequently? Let me see hands. Is it less frequently? Is it a lower dose? Let me see hands. Shorter period of time. So all that's going on. And I think that we have found that over the years we probably are using less. But what's the goal with the NSAID? Symptomatic relief of joint pain and swelling. And it does that. The analgesic effects are immediate. When you start a patient with osteoarthritis or back pain, you really expect relief within 24 or 48 hours. If you're using it for rheumatoid arthritis and you're looking for decrease of inflammation, you got to remember it takes 2-3 weeks for these drugs to work. The dose is always as required, taking the risk factors, cost, comorbid disease, concurrent prescriptions into account. And I think it's now really more the risk factors than the cost. Limitations are, unless you're a mouse or a rat, they don't prevent joint damage. In the animal models, they all do. And the toxicities, there are the toxicities that are annoying to the patient and dangerous to the patient. Dyspepsia is annoying. Gastric bleeding and ulceration is dangerous. Renal insufficiency is dangerous. Confusion, depression can be dangerous. Rash, annoying. Headache, annoying. Retarded clotting time can be dangerous. And NSAID sensitivity can be dangerous. And you have to monitor the efficacy. And you also have to monitor the safety. So in 2001, so it's over a decade ago, NSAIDs accounted for 70 million prescriptions, 30 billion over-the-counter doses sold in the U.S. 10 years ago. A lot of drug use. I want to go through the mechanism of action quickly, just for historical reasons. So John Vane elucidated the mechanism of action of NSAIDs. He won the Nobel Prize for this. Most NSAIDs act as non-selective inhibitors of COX-1, cyclooxygenase, inhibiting both COX-1 and COX-2, and the inhibition is competitively reversible, as opposed to the mechanism of aspirin, which is irreversible. Take an aspirin, you kill the platelets, doesn't come back, you have to produce new platelets. COX catalyzes the formulation of prostaglandins, thromboxane, from arachidonic acid, and the prostaglandins act as a messenger molecule in the process of inflammation. So you need COX-1. You do need it. It's housekeeping. It regulates many normal physiologic processes, protective role in the gastric lining, preventing gastric mucosa from erosion by aspirin. So you need it. And you use an NSAID and you block COX-1, you have problems with the GI tract. Daniel Simmons discovered COX-2 in 1991, and it's facultatively expressed in inflammation, and inhibition of COX-2 does produce the desirable effect of NSAIDs in terms of its anti-inflammatory effects. And if you use a non-selective COX inhibitor, aspirin, ibuprofen, naproxen, it'll decrease gastrin prostaglandin levels, and you can develop ulcers. Most NSAIDs are weak acids, absorbed in gastric intestinal mucosa, highly protein-bound. Most are metabolized in the liver by oxidation, conjugation to inactive metabolites, usually excreted in the urine, although some in the bile. And ibuprofen and diclofenac have very short half-lives, while others, such as oxycams, have very long half-lives. So ibuprofen, it really is an every 4-hour drug. Diclofenac, you can use a BID, but it's really probably more of a TID drug. You have an oxycam like piroxicam, it's got a half-life of over a day. It's clearly a once-a-day drug, maybe even once every 2-day drug. So they do inhibit the activity of both COX-1 and COX-2, and thereby the synthesis of the prostaglandins and thromboxanes. And it's the COX-2 inhibition that leads to the anti-inflammatory activities, the analgesic and the antipyretic effects. So if you had a pure COX-2 and it was safe, really safe, that'd be really good. Medical uses, rheumatic disease, we've certainly used it in rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, reactive arthritis, acute gout, intercurrent gout. So let me ask you an answer question. In ankylosing spondylitis, how many of you use an NSAID first? Does anybody not use an NSAID first? No, nobody. What percentage of your patients in ankylosing spondylitis respond to an NSAID? How many would say less than 25%? What? Complete. You don't need a TNF. I would say less than 25%. 50%. Yeah, that's the number. It's 50%. Already finally got one right. Osteoarthritis clearly is an effective drug, so that's where we use it. Gout, certainly use it acutely, because you can use these drugs short-term. They're safe short-term. I'll show you the data. But you can use it for dysmenorrhea, metastatic bone pain, headache, postoperative pain, so on and so forth and so on and so forth. Lots of uses. So let's talk a bunch about efficacy. Well, not really. It's well established in rheumatic disease, reasonably analgesic, anti-inflammatory, excellent in gout, especially acute gout, effective to a varying extent in OA and RA. They do help relieve pain, probably by 20, 30, 40%, a little bit of anti-inflammatory as well. And they do have a place in our therapeutic armamentarium, but their risk-benefit is the problem, and that's what limits the use. So that's all I'm going to say about efficacy. You know the efficacy. Let's talk a little bit about the safety. So certainly over the past 10 years, 15 years, the adverse events have become very, very much to our forefront. And there are three primary that we think about. We think about GI, cardiovascular, and renal. Dr. Gabriel talked a bit about the cardiovascular yesterday, actually. In the cardiovascular, the NSAID, it's dose dependent. Little is better. Lots of articles on that. And if you look for risk for cardiovascular events and NSAID dose, and now we talk about the dose, I mean, take a look at ibuprofen. Higher dose, much worse. Diclofenac, high dose, much worse. Rofecoxib, Vioxx, much worse. But if you take a look at celecoxib, it's not that much worse. And take a look at naproxen, it's almost zero. Naproxen looks like it's safe in cardiovascular, for cardiovascular. And celecoxib, which has the reputation, actually probably isn't as bad as some of the others, at least in this study. And if you look at death and MI, they increase with the NSAID dose. So this is high dose, low dose again, and ibuprofen. Death, increase. Rofecoxib really increased. Celecoxib increased. But naproxen, not that much. So naproxen may actually be the one that you want to use. And if you look at risk of death increases, this is post-MI. Patient has already had an MI, and now we're at the increased risk. And you can see you raise the dose, it goes up. Celecoxib pretty high, rofecoxib higher, diclofenac pretty high, ibuprofen higher than low dose, but not as bad as some of the others. So you want to use a low dose, or as low as dose as you can. And this talks about time. So we said, so if you take a look at the label, it says they're safe for short term. But take a look at what happens when you really look at the data. When you really look at the data, this is patients prior MI, but it's actually the same patients who haven't had an MI. This is 0 to 7 days, and that's your average. It isn't safer short term. It's a fallacy. It's in the label, and it's a fallacy. And treatment duration, right? So if you take a look, you say, well, yeah, it's true that the longer you use, the higher the risk, but the risk is still higher first month. Don't feel secure that you can use it for a short period of time and not have a risk. That's what the data would seem to suggest. The label doesn't say that. Label's different, and we'll talk about that a little bit later. GI, so there are cell surface effects. There's direct cytotoxicity, decreased mucus and bicarbonate secretion, disrupt the surface phospholipids, and the cellular effects inhibit prostaglandin synthesis, decrease mucosal blood flow, and increase leukocyte adherence. So if you take a look at this is from 2004. Bleeding, NSAID-related adverse events, bleeding greater than 32,000 hospitalizations and 3,200 deaths each year in the U.S. That was 10 years ago. Not benign drugs. And this is where you can have the problem. You have the problem in the upper GI, erosions, ulcers, bleeding, perforations, but the small intestines, ulcers, strictures, enteropathy, and the colon. Colitis, ulcers, strictures, diverticular bleeding, anywhere in the GI tract. And if you take a look, and this is GI side effects induced by non-selective, and you take a look at this bottom corner, dyspepsia occurs in 25 to 50% of patients with or without complications. Very easy to get dyspepsia, give them an H2 blocker, give them PPI, you can get rid of that. It's an annoying side effect. Many patients don't have symptoms. Many patients don't have symptoms. Let's point that out here. What we're worried about is the complications. Ulcers can occur and not be symptomatic. Maybe a little bleed, right? Little decrease, not symptomatic. But what we're really worried about is this. And when do you get it? When is the risk? So some of you may know that my oldest partner, or my first partner, was actually my fellow, is Stanley Cohen. And when Stanley went into practice, Stanley's a very smart guy, went into practice in 1980. He put a patient on one of the new drugs, brand new drugs, because it was really effective. It was a drug called naproxen. Patient took the drug Monday morning, and Monday afternoon called and said, "I'm bleeding. It must be that new drug because I took a tablet." And Stanley said, "No, couldn't possibly do it. Not in one day, right? Not in a few hours." Came in and asked me and said, "I really don't know the data, but why not?" And of course, the patient was scoped and an ulcer. It can occur almost immediately, within just a few days, if not a day. And then you take a look at the risk. That risk is there all the time. It's one of the reasons why we do a CBC on patients regularly to see if they have a slow bleed. And what about dose? Again, this is dose related. Higher dose, more likely, lower dose, less likely, but still occurs even with a low dose. And this is the pooled relative risk of upper GI complications with daily dose of individuals. And you take a look, and you can see there is a clear-cut difference. Piroxicam, that's once a day, very high risk. Ketoprofen, high risk. Naproxen, not a small risk. Indomethacin, a relatively high risk. And then you get into these drugs, diclofenac, Voltaren, rofecoxib, which is Vioxx, celecoxib, ibuprofen, a lower risk, but still there. You can't tell a patient, "I'm going to give you Celebrex, and you're going to not have a problem." Because they're going to reduce your risk 50%, but not 100%. Okay, and the third is renal. So this is the cascade, and there's prostaglandin inhibition, and you really want to take a look through here. You decrease prostaglandins, decrease renal blood flow, decrease GFR, increase BUN and creatinine. And you get all kinds of problems with salt retention, edema, hypertension, decreased renin, decreased aldosterone, potassium retention, hyperkalemia, ADH effect, water retention, and these are things that you really do have to look for. It's one of the reasons why you do a CMP and why you don't see the patient every 6 months or every year and do a lab test. You really do have to do it a little bit more frequently, looking for changes of BUN and creatinine, hypertension. And these are the cardiorenal syndromes that are related to non-selective NSAIDs and COXIBs because they're not different. They're not different. So it's fluid electrolyte abnormalities, CHF, hypertension, acute renal impairment, nephrotic syndrome, papillary necrosis. And it's dose dependent. So this is the risk of acute renal failure increases with NSAID dose and duration. So you can take a look at dose, yellow, blue, right? And then duration. Dose, duration. Bad. Risk of acute renal failure in the elderly increases with NSAID dose. I don't know what the definition of elderly is. I think that's someone over 75. Is that right? 80. 80. Okay. My mother, when she was 88, defined elderly. Elderly was anyone who was 2 years older than her at any point in time. So this is actually over the age of 60, right? And this is the relative risk of acute renal failure versus non-use. You've decreased GFR as you get older. Other adverse reactions, elevated LFTs, headache, vertigo. And then the uncommon are hyperkalemia, confusion, bronchospasm, Stevens-Johnson, interstitial nephritis. Acute renal failure is rare, but it does occur. So the Worldwide Regulatory Agency has certainly called for lower NSAID dose and duration. FDA, EMA, Health Canada, all of them. The treatment guidelines recommend the use of the lowest effective NSAID dose and duration. Multiple guidelines. National Institute for Health, the ACR, multiple, ORSI. So just to show you that I'm current, Dr. Gabriel showed this slide, I think, and this is the FDA meeting that occurred this week. And it was a meeting of the FDA Advisory Committee, the Drug Safety and Risk Management, and the question was, should there be more warnings for prescription and over-the-counter OTC versions of NSAIDs on the potential for cardiovascular events, especially in patients at higher risk for heart attack, heart failure, or stroke? So they asked three things. Asked to consider if the risk changes with duration of treatment, is naproxen safer than other NSAIDs? I showed you the data with naproxen and heart disease, and whether precision, it's an ongoing study of celecoxib versus ibuprofen and naproxen for cardiovascular events. Should it be halted because the data that's already available on naproxen show that naproxen is relatively safe? So she showed what the question was. Here's the result. 1411 voted to reconsider the NSAID label, and probably what's going to come out is that the short term is relatively safe, because it isn't. It isn't safe for cardiovascular, renal, or GI. Shouldn't be in there. But at 16-9 vote, they voted that the warning label on naproxen should not be changed, because the data that I showed you isn't real rigorous data. Right? It comes from observational studies. It really isn't controlled. The precision trial was one of the things that the FDA was asking, should it be discontinued? But that's a very large trial, which actually may answer this question. So they voted to continue the precision and not change the label, not give naproxen a better reputation until precision is done. So the summary, there's a direct association with NSAID dose and risk of select events, higher dose, greater risk. Patients treated with NSAIDs are risk for epigastric bleeding, death, recurrent MI during acute and chronic therapy. And the guidance from the FDA and other medical associations call for the use of the lowest effective dose of NSAIDs. So already asked me about the future. I thought that was actually the most interesting thing you asked me, as well as getting all of this information from glass slides that were all clouded up, right? So here are my predictions. When was the last time an NSAID was approved, which is still available in the U.S.? Does anybody know? Other than Jack, who I'm sure knows. When? 1998. What drug? What? Celebrex. That's still approved. 1998. What's that? 16 years. She should get the prize, right? Give her the money. See Artie afterwards. How many NSAIDs are... Oh, no, you know, I forgot the slide saying right in front of you. Send her to jail. She cheated. Oh, she read it. She read it. Okay, okay. How many NSAIDs new NSAIDs are currently in development? Jack, you want to ask a question, or is that a zero? That's a big zero. So now there have been some differences in NSAIDs, right? So there have been some drugs that are recently approved. There have been combination products, right? But not new NSAIDs. None that I'm aware of or Jack is aware of, so that means none. And I don't think another NSAID will be approved. Jack, what do you think?
No, because the rules are different. When we sat on the FDA advisory board,
Get a microphone.
oh yeah, sorry. When we sat on the FDA advisory board for Vioxx, Celebrex, and Bextra, they changed all the rules. You know, the rules are you develop your drug phase 1, phase 2, phase 3, and because of what happened there, which is another problem, they said for non-steroidals, you're not going to get a new drug on the market unless A, you're different in some substantial way, and B, you actually have phase 4 data to prove it before you're at the time of approval. So you have to have 100,000 patients treated, and it has to be a drug that offers something that's currently not available. So that's why very good COX-2 inhibitors like Arcoxia and Lumericoxib and other ones will never make it to the market, even though they got great portfolios. But because of that rule, they don't. And I think all of that, my own belief, is that's a backlash from the marketing, the over-marketing of COX-2 inhibitors, where it became a multi-billion-dollar industry when it probably shouldn't have been because it was overused, oversold, and it cost the government a great amount of money. So there was this great backlash.
Which was the drug that Lilly had in the early 1980s? It was a dual inhibitor. Began with a B.
Binoxaprofen?
Binoxaprofen.
Yeah.
That's a great example, Jack. So binoxaprofen was a dual inhibitor. It was a COX inhibitor, but it was also a lipoxygenase inhibitor. And it was a very effective drug. And to go to Jack's point, what happened was the marketing people were being paid at that time by how much they would sell. Sell means they come to see you, use the drug, you wrote the prescription, they sold it. So if I forget what the dose was, but if the dose was probably 200, 400. So if you put a patient on 200 and the patient did well, the reps would come and say, try 400, right? Double the money. And there were like 150 deaths in the UK within about 6 months, and that drug was off the market. But it was actually a very effective drug. Okay, so NSAIDs are effective for analgesia and inflammation, and we do use them, but there is significant toxicity, and you have to be aware about that. So there are many patients that can benefit, but they must be carefully monitored. So thank you, and it didn't even take 40 minutes.
All right, Roy, thank you very much for that presentation. I know we have comments and discussion. Let's start front right up here.
Yeah, just my question in patients who have ankylosing spondylitis and, for example, they have coronary artery disease, would you use naproxen based on the data that you showed us? And second question, would you consider aspirin, which has like a higher dose of aspirin as analgesic medication for these patients?
I actually used the aspirin. I don't know if anybody else here has ever used the aspirin, where that's really what you use. The aspirin's a really toxic drug. To get the dose that you would need for AS, all right, forget the tinnitus, there's going to be a bleed, there's going to be something. I don't think that you can do it. It's hard. It's hard. So the drugs, actually, there are only 2 NSAIDs that I'm aware of that are approved for ankylosing spondylitis. One is Celebrex, and the other is diclofenac. I'm not aware of any of the others. When you talk about heart disease, I think you really talk about hypertension. Right? I think that's really what you're talking about. So I put a patient on an NSAID, and it could be any of the NSAIDs. It could be naproxen, could be Celebrex, and I'm watching the blood pressure. So that's what I do.
Okay. Even if they have like coronary artery disease in the past, like in mine, they have stents or.
No.
Yeah.
So that patient, I'm going to go to a TNF.
You go directly to
I'm going to go to a TNF.
Okay.
His first question, do you believe that naproxen is better for heart risk? I think that was your first question.
I think that so it depends upon how you look at the data. I am a purist when it looks at the data. The study is now being done, right? We have other people here who are not quite as pure, who will say that the body of evidence, right? Alvin's laughing because he's one of them, right? No, there's a body of evidence, and the body of evidence all seems to point to naproxen actually being a little bit safer.
Is there an explanation for that? Like why naproxen has less side effects than cardiovascular side effects than other NSAIDs?
Because it affects the platelets reversibly, like aspirin does.
Okay.
Celebrex doesn't do it. Celebrex doesn't do. We actually did the studies. We did the studies with Celebrex. We did it with Nebumetone, and we did it with one other drug in orthopedic procedures because the orthopedists didn't want to use NSAIDs, where we showed it doesn't affect bleeding at all. It didn't affect the bleed. But aspirin does, right? And naproxen does it for a shorter period of time. It's reversible with naproxen quicker.
Okay, thank you.
Roy, very nice job. Quick question. So
You're always
I
so
was-
kind.
Well, thank you. I was hoping you're going to tell me that, hey, I can abrogate some of these side effects. And, we know with PPIs for the GI stuff, but what about if I give the patients on Celebrex and aspirin? Is that going to help out? And maybe in the precision trial, are they on aspirin as well?
In the precision trial, they can be on a baby aspirin, right? That I know. So what was the other? I think it does, right? But what? But I said I think it does. So let me finish the sentence. But that trial is the precision trial. If the FDA stops that trial, because remember it's an advisory committee, right? As Jack will tell you, you give the advice. They rarely go against it, but they can. But that's the one trial that may really answer that question. And then the other question you asked was about GI, right? And you can abrogate. So Celebrex does do, celecoxib, CME, right? Celecoxib decreases the GI ulceration rate by 50%, right? Are you listening? Alva, do you care? Okay. So decreases it by 50%, right? But it's 50%. If you add a PPI, you decrease it by another 50%. So it's 25%. So you were probably around and probably at the meeting that Searle had at the introduction of celecoxib. Was anybody there? No? Probably. Oh, Jesus. Probably. I know which meeting. I really am old. Anyway, so the guy who actually ran the program got up there and said, today is the day I've been looking for. It's the day I'm going to tell my mother that she can now take an NSAID because she was on warfarin, right? And it's safe because she won't develop an ulcer. That's how he started his talk, right? And after his talk, his name was Steve something. And after the talk, I said, "Why do you hate your mother?" And he said, "What do you mean?" And I said, "You've decreased the risk. You haven't eliminated the risk. She still has a 25% chance of a bleed." Calls me a week later and said, "Did you put the curse on her? Went on Celebrex, had a major bleed." So even these things, they reduce, but they don't eliminate. Marty?
Yeah. Two quick questions. The first is, in the original Willow Bark study, what were your primary outcomes?
Okay, wait a second.
And the second question...
No, wait a second. I think that is the most clever question of the meeting. So the original outcome of that trial... No.
The second question is sort of in the same aspirin theme, though. Everybody and their sister is coming in on baby aspirin these days, or in some dose of aspirin. What are you advising your patients, and what is your practice in patients who you think need an NSAID but are on a baby aspirin already?
So we talk about that, because you have to talk about that, right? And I actually do try to get everybody on a PPI. And what I tell them is there's always a risk. And there is an absolute risk just with a baby aspirin, let alone an NSAID. But I start out by asking people whether or not they're using less NSAIDs. And we are. I mean, I take a patient who has rheumatoid arthritis. In the old days, 1997, I'd put him on methotrexate, right? I put him on low-dose steroids. I put him on an NSAID. I put him in a study with the TNF, right? Get everything under control. I try not to put him on NSAIDs now. I'd rather use a TNF, methotrexate, and low-dose prednisone, and get him off the prednisone. They are scary. They're effective drugs. You need them at times, but they are scary.
Roy, a question about the non-acetylated salicylates, older medicines. I think I'd love to hear what your experience. I think my sense is that they weren't perhaps not as efficacious, but that they were safer than other non-steroidals.
Yeah.
What do you
So
think?
if we go back to, I don't know if it's not up there. So there's a drug called salicylate, right, diflunisal, and those drugs are non-acetylated, and they certainly were safer, and they were certainly tolerated better, and they certainly didn't work better.
Did they work at all?
Yeah, no, I mean, the trials, I mean, to answer Marty's point,
yeah.
the trials showed that they worked, and that's why they were able to get approval, because in the old days, all you had to do was show efficacy, and they did work, but they really were not that effective. Now, that doesn't mean that I don't have, I think I still have one patient with diflunisal. It's been on it for a long period of time, and it works. So when you talk about groups of patients, I didn't think that they were that helpful. So I just want to go to that slide because that really is history. So what I already saw, so there was aspirin, and that's salicylic acid, right? And it's the flunisol and salicylate and that's what I couldn't remember, trilosate.
Trilosate.
Yeah,
Yep.
choline-magnesium trisilicate. And they were safer, not quite as effective.
Jack?
So, Roy, any comments and suggestions on managing nonsteroidals with surgery? And then also with anticoagulant use. So, surgery, obviously we have to stop them and whatnot, but there is some data about continuing nonsteroidals even through surgery with nabumetone and even with celecoxib, that it actually isn't that big of an issue, but it still is generally thought you should probably stop those. What's your thought on that?
So we did the studies. We did the studies with celecoxib. We did it actually with Dickie Jones and did it in surgery. Mm-hmm. So it was celecoxib, nabumetone, and etidolac. Mm-hmm. Those three, if you give the patient, it does not change anything in terms of their bleeding time or anything. So if a patient's on, and I will start with one of those drugs actually for that reason. So the patient comes in and they're going to have surgery, and they said the surgeon wants me to stop this drug a week before surgery. So I said, okay, this is what you do. Tell them you stopped it, but don't. Right? Or you can stop it if you've been hurting, start it, but don't. And then if they catch you, tell them it was, that it was me, because who's going to come to me and yell at me, right? The other drugs, though, if you're using naproxen, right, I think that is an issue. Certainly if you're using aspirin, it's an issue. If you're using indomethacin, it's an issue. Those other drugs, I do stop them a week before until a few days after surgery.
I think an often overlooked issue is the bleeding potential when you're on even these newer antiplatelet drugs and non-steroidals.
Why wouldn't you be? So but that's the problem. The problem is if you're on a blood thinner of any type, and you're taking the best drug to prevent GI ulceration, which is celecoxib, and you put them on the best PPI, right? So it's a 25% risk. But if you're on Pradaxa and you happen to have a bleeding ulcer, it's bye-bye. Now, I do have patients who do it because they really need the NSAIDs. But let me tell you, my chart says very specifically, I spoke to the patient about this, this, and this is what the patient decided to do in spite of that.
All right. Well, thanks very much, Roy. Okay, we're give the lights up. We're just